All right, so thank you so much for inviting me to speak today in this forum. As Ariel mentioned, I'm the program psychiatrist for the Reconnect program within the Council on Aging Southern California. And the goal that drives the work of the Council on Aging is to keep seniors healthy, connected, and protected. And my hope is that this presentation helps educate and empower all of us to stay healthy, connected, and protected as well during this pandemic. So today I'd like to start by providing an overview of the COVID-19 pandemic as it stands today in the US, California, and here in Orange County. I'll then discuss what we know about the mental health impacts of the pandemic on the population at large and specifically for older adults and caregivers. And finally, I'd like to cover evidence-based strategies for coping during a pandemic, drawn from research on prior mass casualty events and natural disasters. Please feel free, as Ariel mentioned, to type any questions you may have into the chat box as they come up, and I'll try to answer them to the best of my ability at the end of my presentation. So I wanted to provide a snapshot of where we stand as of yesterday, with the caveat that the Thanksgiving holiday has led to some delayed reporting in the US. The WHO COVID-19 dashboard reports 62.4 million cases and 1.46 million deaths worldwide as of yesterday. The Johns Hopkins Center for System Science and Engineering dashboard reported 13.5 million US cases and 267,888 deaths as of yesterday. The US is averaging about 162 new cases per day, which is the highest since May. We're averaging more than 2,000 deaths per day. As a reference, our prior peak was around 2,200 deaths a day in late April when New York City was the epicenter. As a comparison to the worldwide number we just saw, the US accounts for 4% of the world's population, but has more than 20% of the COVID-19 cases worldwide. We have the highest total daily incidence globally, and put another way, more people are infected with and die from coronavirus in the US than anywhere else in the world. Here are the trends as of November 30th for the US per the COVID tracking project. So going from left to right, the number of daily tests, the number of daily cases, the number of people currently hospitalized, and the number of daily deaths on the right. As you can see, we are in the third wave or surge of cases, which is worse than the first two. They note that what appears to be a slight decrease in tests, cases, and deaths are due to reporting delays from the holiday, so we'll have more of an idea of the true numbers later this week. Also, as a reminder, the number of daily deaths lags behind the number of cases diagnosed because the course of illness for severe COVID means that many folks succumb to the illness 3 or 4 weeks or more after being diagnosed. So we just had Thanksgiving last week, and to put it in stark terms, people who got infected from Thanksgiving travel or gatherings will start to be diagnosed over the next 2 weeks, hospitalized in mid-December, and die from COVID around Christmas and New Year's. The number of cases is unfortunately projected to increase due to holiday-related infections. Zooming into our state, these are the numbers as of yesterday, November 30th, for California from the California Department of Public Health website. We were at over 1.2 million cases alone just in California, over 19,000 deaths, 7,787 confirmed cases hospitalized, with 1,812 of those in the ICU. In a press conference yesterday, you may have seen this, Governor Newsom noted that the 7-day average in new daily cases was 14,657 on Monday, compared to 9,881 at the height of the July summer surge that we had here in California. Over the past 14 days, COVID hospitalizations have increased by 89%, and COVID ICU admissions have gone up 67%. On Sunday, California broke a record with more than 7,400 coronavirus hospitalizations. Current projections show hospitalizations could increase 2 to 3 times the current amount in this next month, because again, as I noted with the last slide, we have not yet seen the impact of the Thanksgiving holiday in terms of hospitalizations and deaths. In Southern California, 74% of ICU beds were occupied as of yesterday. Based on current trends, that number is projected to be at 107%, meaning over capacity by Christmas Eve, according to data from the CDPH. Governor Newsom said Monday that if troubling trends continue, the state may take more drastic action, which could include stay-at-home orders, but he also expressed confidence that we'll be able to bend the curve again to avoid overwhelming our healthcare system. And this is our dashboard for Orange County as of yesterday, which is available on the Orange County Healthcare Agency website. As you can see, our number of hospitalizations has already been increasing. We are in the purple tier, or the highest tier, as are all of our surrounding counties and more than 95% of residents in California. You may have also heard that LA began a 3-week stay-at-home order yesterday in response to their rapidly increasing numbers. And for reference, LA had almost 5,000 new cases yesterday, but we had the second highest number with 1,175. So we've now established with data the increased risk that our older adult population faces in terms of age-related increases in morbidity and mortality. The CDC published this graphic in August to demonstrate how the risk increases by age, but not in a linear fashion. So as you can see, the risk for hospitalization and death increased precipitously for folks 75 years and older. We're seeing for ourselves in California that older adults are disproportionately at risk. In Orange County, 74% of deaths have occurred in adults 65 and older, while 38% of all deaths have occurred in assisted living or skilled nursing facilities. This is on track with the numbers for California and the US as a whole. So less than 1% of Americans live in long-term care facilities, but as of November 26, they accounted for 39% of US COVID deaths. My colleagues who will speak after me will go into greater detail about long-term care facilities, but I just wanted to highlight that despite efforts to keep COVID out of nursing homes, incidents among residents and staff are rising after a period of relative stability. Despite federal and state investments, strategies, and guidelines, nursing home staff are inevitably exposed to community transmission, which then puts their residents at risk. A study of nursing homes found that nearly 25% of facilities reported some sort of staffing shortage, and 20% reported a shortage of PPE in the last week of October. The study also found that 1 in 6 nursing homes had not tested staff in the previous week, despite a national mandate for such weekly testing. A different study conducted by researchers at the University of Chicago on behalf of the Associated Press found that nursing home quality was not a meaningful predictor of success against COVID-19 after accounting for the level of community transmission. So the takeaway is that the best way to protect our most vulnerable populations of older adults and residents of long-term care facilities, or our children in schools, or really anyone, is to effectively contain community transmission, and that it is very difficult to do so without a broad community-based strategy. I now want to focus on what we've learned about the mental health impact of COVID-19, both for those who have actually contracted COVID, as well as for the general public as a consequence of this pandemic, which is a mass casualty event drawn out over months. I'll also speak to what we know about the mental health of older adults and caregivers during this pandemic specifically. A study recently published in The Lancet Psychiatry was an analysis of electronic health records of 69 million people in the US, including more than 62,000 who were infected with the novel coronavirus, and found that 20% of those infected were diagnosed with a psychiatric disorder within 90 days. They found that adults have an approximately doubled risk of being newly diagnosed with a psychiatric disorder after COVID-19 diagnosis. Anxiety, depression, and insomnia were most common among recovered patients in the study who developed mental illnesses, and the researchers also found significantly higher risks of dementia and neurocognitive disorders, excuse me. Also, a psychiatric diagnosis might be an independent risk factor for COVID-19. A psychiatric diagnosis in the previous year was associated with a 65% higher incidence of COVID diagnosis. Possible explanations for the association include behavioral factors, for example, less adherence to social distancing recommendations, and residual socioeconomic and lifestyle factors like smoking that were not sufficiently captured by the available data in any of the studies. It could also be that the vulnerability to COVID-19 is increased by the pro-inflammatory state postulated to occur in some forms of psychiatric disorder, or be related to psychotropic medications. Though on that note, interestingly, the antidepressant fluvoxamine, or Luvox, is being studied currently as a possible medication for those with mild to moderate COVID to prevent serious illness. COVID has also affected the mental health of our population at large. The proportion of Americans reporting a negative impact on their mental health due to the pandemic is increasing, as noted in this Kaiser Family Foundation survey, which has been tracking these factors since the beginning of the pandemic in March, as you can see in this chart, but has not been updated since July. More than 1 in 3 adults in the US reported symptoms of anxiety or depressive disorder during the pandemic in May, and this number went up to 4 in 10 adults by July. By comparison, this is 3 times the number of adults reporting symptoms compared to last year, and I would suspect that any data collected after July would reflect further increases. This same Kaiser Family Foundation poll from July noted that overall, 40% of respondents reported at least one adverse mental or behavioral health condition, including symptoms of anxiety or depressive disorder, symptoms of a trauma or stressor-related disorder. Also, 13.3% of adults reported having started or increased substance use to cope with stress or emotions related to COVID-19. 10% of adults reported serious thoughts of suicide in the past 30 days. This percentage was significantly higher among respondents aged 18 to 24, minority, racial, and ethnic groups, self-reported unpaid caregivers for adults, and essential workers. I wanted to discuss some of the factors that are contributing to the worsening mental health of Americans due to the pandemic, some of which are due to the public health and economic crises that we're living through, and many of which stem from pre-existing conditions, if you will, that were in place prior to COVID-19, including structural inequalities. Research shows that job loss is associated with increased depression, anxiety, distress, and low self-esteem, and may lead to higher rates of substance use disorder and suicide. We lost 22 million jobs in the US from February through April, and we're still down 10 million jobs as of November. Recent polling data shows that more than half of the people who lost income or employment reported negative mental health impacts from worry or stress, and lower income people report higher rates of major negative mental health impacts compared to higher income people. Next, a broad body of research links social isolation and loneliness to poor mental health. And data shows that significantly higher shares of people who are sheltering in place reported negative mental health effects compared to those not sheltering in place. In particular, isolation and loneliness may present specific mental health risks for households with adolescents and for older adults. Also, poor mental health due to burnout and trauma amongst frontline workers is a major concern. We're particularly concerned about healthcare workers in hospitals and long-term care facilities, many of whom had to deal with the disconnect between what they see at work and how people have been acting in their communities. Those with mental illness and substance use disorders pre-pandemic and those newly affected will likely require mental health and substance use services that were in short supply before the pandemic, and now there may be even more barriers to care. I also wanted to mention gender roles here because polling data shows that women with children under the age of 18 are more likely to report major negative mental health impacts due to the pandemic than their male counterparts. This is likely due to the unequal burden of childcare and household duties in many families. Also, the economic data is pretty grim. 617,000 women, nearly 8 times more than the number of men, dropped out of the US labor force last month as the pandemic continues to exacerbate inequalities in our economy. Half of the women who dropped out were in the prime working ages of 35 to 44. And I also wanted to acknowledge that this has been a tumultuous, painful year in terms of how we as Americans have been grappling with the effects of racism in our society, politics, and healthcare systems. The pandemic has uncovered and exacerbated racial inequities in terms of greater mortality rates for people of color. According to the CDPH, we are seeing that Latinos, African Americans, Native Hawaiians, and Pacific Islanders are dying at disproportionately higher rates in California due to COVID. Black and Hispanic children are at higher risk for multisystem inflammatory syndrome in children. More than 75% of all cases have occurred in these ethnic groups. So it's unsurprising that the Kaiser Family Foundation poll found that greater numbers of Hispanic and Black adults say they have experienced adverse effects to their mental health and well-being as compared to white adults. Many professional organizations and health departments across the world have been particularly concerned about older adult mental health, partially because of the realities of how they are at higher risk for morbidity and mortality due to the virus, and because many were already at higher risk for loneliness and social isolation even before the pandemic. Unfortunately, the polls and studies that have been looking at older adult mental health have confirmed thus far that there have been negative impacts. The Kaiser Family Foundation poll I referenced before show a recent increase in the share of older adults reporting negative mental health impacts due to worry and stress from the coronavirus, as shown in this chart, going from 27% in March to 47% in July. Another study out of Indiana University also found that older adults are experiencing greater depression and loneliness than they had prior to the pandemic. However, though we know that there is a negative impact on mental health overall for older adults, a recent article in JAMA summarized evidence of some individual studies from different countries, including a survey by the CDC published in August, which showed that at least some older adults are not experiencing disproportionately increased negative mental health consequences commensurate with the elevated risk they faced during the first few months of the pandemic. The evidence suggests that counter to expectation, some older adults may be more resilient to the anxiety, depression, and stress-related mental health disorders characteristic of younger populations. The authors cautioned that this trend was only seen with data in the first couple months of the pandemic, and that underrepresented minorities or caregivers are at disproportionately elevated risks of experiencing negative health outcomes. I just wanted to mention this because the finding of higher resilience to the mental health effects of COVID-19, at least in a proportion of community-dwelling older adults, is really important for future research to understand the mechanisms and factors that drive this resilience. I wanted to mention caregivers, as many of our older adults are caregivers as well, in addition to being care recipients, whose mental health would also be impacted by how their caregivers are doing. We're seeing studies indicating that, as we may have guessed, the pandemic has exacerbated many of the pre-existing stressors and challenges that caregivers have faced. So caregivers' mental health is being impacted in a negative way, more so than non-caregivers. A community survey done by the University of Pittsburgh in July showed that family caregivers were more likely to report taking precautions and having worries about getting themselves or their care recipients sick, and also were more likely than non-caregivers to be experiencing social isolation, anxiety and depression, fatigue, sleep disturbance, financial hardship, and food insecurity. Caregiving as a whole has also gotten more difficult because of the pandemic. Family caregivers report that, that the pandemic has increased their caregiving responsibilities and that providing care is more emotionally, physically, and financially difficult. This was largely due to interrupted access to care, both for themselves and their care recipients, and the resulting lifestyle adjustments that have led to reported increases in worries, fear, depression, and anxiety. As an example, a huge burden has been placed on our caregivers in Orange County caring for recipients with neurocognitive disorders or dementia at home who used to go to adult daycares because those daycares are still closed. Also, the negative impact of the pandemic has unfortunately fallen unequally amongst caregivers. Female caregivers, minority caregivers, caregivers with less education, caregivers with lower income, younger caregivers, caregivers who care for persons with mental health or behavioral issues, and caregivers who live with the care recipient tend to report greater negative impacts of the pandemic. I also wanted to present some anecdotal information from our Counsel on Age and Reconnect program case managers who work with older adults who are also caregivers, as well as from my clinical experience working with our program participants over the past 8 months. There are themes to the concerns that our participants are expressing that are reflective of the data that I've already presented. First, again, anecdotally, we too are seeing increased rates of depression, anxiety, suicidal ideation, loneliness, and cognitive symptoms. Secondly, there is a theme about less access to, or in many cases, the complete loss of respite care, like adult daycare that I just mentioned. Many older, many older adult caregivers are reporting that they have no respite now and are feeling exhausted with caring for their loved ones without any relief in sight. Many report that it's been challenging to coordinate or access care for their care recipients and or themselves due to disruptions in healthcare delivery in the past few months. Transportation services have been limited or paused due to the pandemic, and many of our participants relied on these services, which has been very challenging. Social isolation has been particularly difficult for older adult caregivers in terms of being able to access their own social support. Also, for caregivers whose loved ones are in nursing facilities, this has been a very stressful time as visitation has been drastically restricted. Other older adults are reporting family conflicts that have arisen out of spending more time with their family members than they usually would, who may also be facing their own stressors of unemployment and worsening mental health. And finally, I would say that based on my own anecdotal evidence, 90+% of the participants that I'm seeing for consultation either do not have access to a smartphone or laptop for video conferencing, or do not have the ability to figure out how to connect via their smartphone, and unfortunately don't live with anyone who can facilitate this for them. This is an obvious example of the barriers that this vulnerable population face for accessing care remotely and has implications on the type of interventions that are most likely to be helpful for them. So to sum up what I've presented thus far, the pandemic is far from over and is getting worse. A secondary mental health pandemic, if you will, has been developing and will be dealing with impacts of both for years to come. Older adults and caregivers are amongst our most vulnerable populations, both for COVID-19 and the negative mental health impacts of the pandemic, particularly those in ethnic minority populations, those with lower socioeconomic status, and women. It is, to put it mildly, not looking great. That being said, we are not helpless in the face of these difficult times. We've seen incredible cooperation, research, and development within the scientific community to rise up to the challenge of this pandemic, some of the results of which I will go over in a little bit. And it turns out that social scientists have also identified an evidence-based approach that may be helpful that I'd like to share with you today. In 2007, a worldwide panel of experts on the study and treatment of those exposed to disaster and mass violence collaborated to extrapolate from related fields of research and reach consensus on these 5 principles for different individual and community-based interventions in the early to mid time periods following a disaster and mass trauma event, which I think could be helpful broadly to protect our collective mental health in the context of the pandemic. The 5 principles are to promote a sense of safety while balancing a realistic assessment of the ongoing danger, promoting a sense of calm to cope with the many intense emotions that can arise, to promote a sense of self and community efficacy, to promote social connectedness and attachment, and finally, to instill a sense of hope. So first, we must promote a sense of safety. We know that this is important because of studies that show that even for people living in conflict zones where threats can continue, that those that can maintain or reestablish a relative sense of safety have considerably lower risk of developing PTSD in the months following exposure to trauma than those who do not. Safety must be approached as a relative state, which is definitely true for us when thinking about a pandemic caused by a respiratory virus. Some ways that we could promote the sense of safety in our situations are to provide education about how COVID-19 spreads and the best practices to avoid the infection, which my colleagues will go over later this morning, or to establish routines which provide a sense of safety and predictability. It's also important to think about psychological safety, as defined as a belief that one will not be punished or humiliated for speaking up with ideas, questions, concerns, or mistakes. We can encourage psychological safety by offering empathy and emotional support to our loved ones and colleagues, given that the pandemic has been challenging for all of us. It's important for many reasons to be able to access a sense of calm. Of course, some anxiety is a normal and healthy response when faced with unprecedented threats like a pandemic. However, we want to be able to manage the intense emotions and arousal that may ultimately impair our functioning if they continue for too long. Some strategies for accessing calm include deep breathing, yoga, meditation, deep muscle relaxation, imagery, music, and increasing activities to foster positive emotion, also known as behavioral activation. I thought it was interesting that the experts also addressed the importance of managing how much media or news is consumed as a method to promote a sense of calm. They recommended limiting media exposure to 3 times a day, once in the morning, afternoon, and early evening, but not near bedtime, or agreeing to get news reports from a friend or family member who would give the facts without the image and hyperbole used in much media reporting. Self-efficacy, which is a concept defined by the psychologist Albert Bandura, is an individual's belief that his or her actions are likely to lead to generally positive outcomes. Improving one's self-efficacy or confidence in the ability to exert control over one's own motivation, behavior, and social environment is at the core of many therapeutic strategies and is being studied as we speak in many contexts within the pandemic, including education, for example. Collective or community efficacy is the sense that one belongs to a group that is likely to experience positive outcomes, or a group's shared belief in its capability to organize and execute actions required to achieve goals. Both of these can be enhanced through therapeutic strategies. Excuse me. Cognitive behavioral therapy, for example, is designed to encourage active coping and good judgment about when and how to cope, elements that are critical in raising or regaining self-efficacy. One strategy I wanted to highlight for us to use as individuals was the importance of a process mindset, or breaking down a problem into small, manageable units, and then concentrating on tackling those units. This mindset can help keep us in the here and now, even during the pursuit of distant goals, and also creates regular opportunities for little victories, which can help sustain motivation. Some other examples to use for our family units are to stay active in a cause for kindness and connection, like making art or compliment cards for first responders, finding ways to volunteer remotely for a local nursing home, or helping our local food banks, which are dealing with unprecedented need. We can also create collective mastery experiences or essentially group projects with attainable goals like organizing a closet together or embarking on a family workout exercise challenge. For both individuals and families, we can encourage reflection and communication by, for example, identifying and sharing a small realistic goal for each family member to accomplish each morning, then having time to discuss those goals in the evening. The experts also noted, however, that empowerment of self-efficacy without resources is counterproductive and demoralizing. Research on disasters and trauma has repeatedly found that those who lose the most personal, social, and economic resources are the most devastated by mass trauma, while those who are able to sustain their resources have the best ability to recover. It's critical for community efficacy to give people the resources they need to rebuild. So we can collectively advocate for our healthcare workers to have the supplies they need, or to provide economic assistance for those industries and communities who have been hit the hardest. There is a tremendous body of research on the central importance of social support and sustained attachments to loved ones and social groups in combating stress and trauma. Social connectedness increases opportunities for knowledge essential to disaster response. In our case, something like where can I buy toilet paper or hand sanitizer, while also providing opportunities for a range of social support activities like practical problem solving, emotional understanding and acceptance, sharing of traumatic experiences, normalization of reactions, and mutual instructions about coping. All of these also can lead to a sense of community efficacy, as we just discussed. The challenge has been how to accomplish this in the midst of a respiratory pandemic. At this point, we've all had almost 9 months of experience with figuring out how to stay connected. And I imagine for many of us, that has required being creative with virtual connections, from setting up Zoom or FaceTime happy hours or group chats, or figuring out the safest possible socially distanced outdoor setups to see friends and family. The challenge when it comes to older adults is something that has been described in one article as the COVID-19 social connectivity paradox, in that as the level of an older adult's physical interactions with others increases, it can protect against social isolation and disconnectedness, although it can increase the risk of COVID-19 exposure, while the converse is true. The more protected you are from COVID-19, the higher risk you may have for loneliness. One recent article on this topic to address the older adult COVID-19 social connectivity paradox proposed a CBT approach for intervention with older adults I wanted to share with you, as loneliness and stress related to social isolation can be conceptualized as being caused and maintained not just by objective circumstances, but also by our thoughts, behaviors, and feelings surrounding these experiences, as illustrated on the left of your screen by the classic CBT cognitive triangle. Teaching an older adult to understand his or her experience of loneliness or isolation through the CBT lens can foster a sense of agency and control, which increases self-efficacy. And one can also identify tailored intervention strategies to reduce distress, as noted on the diagram and in the connections plan on the right, like changing one's perspective with self-talk, changing uncomfortable body sensations that come up when someone feels lonely, or changing one's ways to connect. Folks with limited family support and who may have been isolated prior to COVID-19 will have fewer resources to draw upon when creating a connections plan. So strategy in those instances may be to focus on distress tolerance strategies and finding ways of feeling safe and comforted without other people. The authors noted that the connections plan allows for many types of connections with people, animals, nature, a higher purpose, or spiritual connections, and noted that all of them have value, including connections with people who are not close family or friends, or weak or peripheral ties in the social network, which are strongly linked with more positive mood in older adults. So every connection matters. The final principle is to instill hope, as there is strong evidence for the central importance of retaining hope following mass trauma. Instilling hope is critical because mass trauma is often accompanied by a shattered worldview, the vision of a shortened future, and catastrophizing, all of which undermine hope and lead to reactions of despair, futility, and hopeless resignation, that feeling that all is lost. I imagine that all of us may have had moments like this in this past year. This is a critical piece for coping with this pandemic, as these reactions of futility and resignation can paradoxically lead to continued community transmission and deaths if people believe that they do not have the power to change the outcome of their communities. The experts found that what is most critical to maintain hope is to provide services to individuals that help them get their lives back in place, such as housing and employment. In a study of veterans with combat-related PTSD, employment status was found to be the primary predictor of hope. Likewise, one of the strongest predictors of PTSD for victims of Hurricane Andrew was the inability to secure funds to rebuild their homes. As I've discussed previously, on a societal level, we can advocate for our community organizations, cities, and states to get the funding they need to do this important work of first controlling the pandemic and then building back our economy, and ultimately to instill hope on a community level, which would basically be a public mental health intervention writ large. On an individual level, some strategies include decatastrophizing. Although catastrophizing is a natural response to trauma, it should be identified and countered by more fact-based thinking. Paradoxically, envisioning a realistic, challenging, even difficult outcome may actually reduce people's distress compared to envisioning an exaggerated catastrophic outcome. We can also do what is called benefit finding in a balanced way. That is to think about and embrace what has helped you or your family find strength, meaning, and comfort in other difficult situations or during this pandemic. It's important, of course, not to minimize the possible challenges your family and community might be facing, or to gloss over them in favor of finding those silver linings. So to end my presentation, I wanted to share some good news and real reasons for hope in terms of recent developments that will help us to combat this pandemic. First, you've probably already heard the good news about both the Pfizer and Moderna vaccines, which released preliminary analysis, which showed that vaccines could be over 90% effective, which is fantastic when compared to, for example, 33 to 61% for annual flu vaccines. No serious adverse events have been reported thus far among trial participants, and both have submitted their application for emergency use authorizations under the FDA. Dr. Fauci and other experts have anticipated widespread availability in spring of 2021. In terms of the latest cautiously good news in terms of therapeutics, the FDA issued an emergency use authorization for the use of bamlanivimab, a monoclonal antibody as a COVID-19 treatment in some patients who are at high risk for severe disease, are currently experiencing mild or moderate COVID-19 disease, but not currently hospitalized. This will continue to be evaluated, but the data currently available shows that the drug can reduce hospitalizations and ER visits in these patients. Also, nebulized interferon beta 1A is another therapeutic associated with higher odds of clinical improvement from COVID-19, according to a phase 2 industry-funded study in the Lancet Respiratory Medicine. All this to say, I did not list all of the different potential therapeutics that are being developed, but there are many. In terms of masks, the evidence has shown that they are beneficial both for protecting oneself and others. The CDC has finally updated their guidance online to reflect this, which is good news, and will hopefully lead to more folks cooperating. So all of what I've just shared should by no means encourage any complacency about COVID, given the dire situation we're in currently, but we have been able to make remarkable progress over the past 8 months as a scientific community, and I have hope that we'll continue to pull together to protect our most vulnerable populations. As this graphic, created by Dr. Ian McKay, an Australian virologist, shows, we have many ways to defend against this virus in the same way that there are many strategies to employ for protecting mental health. No single intervention is perfect. Each intervention or layer will have imperfections, but multiple layers improve success. This is a brief list of resources in Orange County for older adults and caregivers. These are my references, and with that, I thank you so much for your kind attention, and now we'll go to any questions you may have.
Thank you, Michelle. I have a couple questions that have come in from our attendees. I'm going to start with one of them right now. Does isolation and lack of socialization for an older person living alone in their own home exacerbate the onset of dementia or memory issues? If so, is this a temporary or permanent loss?
That's a great question, and not one that I think we can answer thus far in terms of data. We know that in terms of the different studies that I looked at with the negative mental health impacts of the pandemic, that there are more people reporting cognitive symptoms as a result. And we also know that some of the ways that we treat behaviorally neurocognitive disorders is to maintain routines, encourage socialization, and all of those routines have been disrupted due to the pandemic. Whether or not that's reversible, I think remains to be seen. In general, neurocognitive disorders are a degenerative type of process, which continues to get worse. However, I think the jury's still out because hopefully we'll be able to resume some of those routines fairly soon. And then it's a question of whether or not folks are going to be able to respond to those interventions. For example, going back to an adult daycare, having more socialization activities. We'll have to see whether or not we can reverse some of the losses that have occurred in terms of cognitive symptoms.
Okay, great. I have 3 additional questions. The next one is, what are the most reliable resources for up-to-date information?
Okay, I'm assuming that we're talking about for COVID.
Yes.
So, yeah, okay. So many of the resources that I listed up front in terms of the numbers are reliable sources. So the things that I use daily are the Orange County Healthcare Agency dashboard, which presents the data from Orange County, which is most relevant for most of us in terms of making decisions about what we're going to do, looking at the risk, kind of figuring out what's happening in terms of hospitalizations. I also use the CDPH website, the California Department of Public Health website, which gives lots of great up-to-date information about, for example, the new orders that may be coming down from the governor's office or public health. And so I use that also on a daily basis. Some of the other websites that I used to present some of the slides, for example, the Johns Hopkins Center for Security sends out a couple times a week, every other day, a newsletter. I'm happy to provide the link to sign up. It's free for anyone to use and presents great data worldwide. Also, the newest updates, if you will, about therapeutics. And I also use different things like the COVID tracking project, which is a project started by the Atlantic, which came up with those 4 charts that I indicated that you can look at for just tracking what's happening in the US. That's less relevant, I think, for our daily lives, but also super important information. And that's also available online, and I follow their Twitter account, and all of those links I can provide afterwards.
Great. I have a couple more. And so the next question is, what can we do to emotionally help a loved one who is at risk and whose mental health has declined during the pandemic?
Yeah. Well, this is a situation that I imagine many of us are in, because as I presented, negative mental health impacts have been felt by an increasing number of our population, not just in older adults and caregivers. I think it depends. So, with any sort of intervention or sort of the advice that I provide for any family member looking to help a loved one who is suffering from mental illness or having a tough time, I think the first principle is always empathy, is to try to reach out with empathy and to ask what's going on and to try to get more information. NAMI is a great website, the National Alliance for Mental Illness, in terms of figuring out maybe more specific information that may be relevant for your loved one's particular needs, due to their diagnosis or proposed diagnosis. Another thing that I want to mention, that I mentioned previously in terms of providing a sense of safety. So that psychological safety is important to make it, and it's part of empathy, to try to make a safe environment for folks to be able to reach out when they need help. And of course, this is a problem even pre-pandemic, as I mentioned, in terms of access to care. It can be really difficult to access high quality mental health care, but it's a really important thing to think about and to encourage for our loved ones who may be going through a tough time, to reach out to their mental health providers, or medical providers. So I'm family medicine and psychiatry as well, and I know that my primary care colleagues deal with about 80% of mental health complaints, and that's a great place to start. If you have a trusted relationship, if your family member has a trusted relationship with a primary care provider, to just bring it up at their visit or make an appointment to say, hey, I'm having a tough time.
Okay, great. We've got some more questions coming in for you. So the next one is, what do you suggest for a single parent who lives alone and seems cognitively clear on the phone, but confused in person? Is this isolation related?
Okay, what was the beginning of that? It's a single parent?
Yes, a single parent who lives alone and seems cognitively clear on the phone, but confused in person.
Okay, so maybe this is so I was getting confused with single parent. So not a single parent of children, but like a parent who lives alone. Okay, I
Correct.
think.
Correct.
Okay,
Yes.
all right. So that is a really important thing to note. With neurocognitive disorders, there are many different kinds of neurocognitive disorders or dementias, and some of them do present in a kind of waxing and waning way, meaning that the symptoms can kind of fluctuate throughout the day. Symptoms can fluctuate depending on what's happening. The most common phenomena is that goes along with this waxing and waning presentation is sundowning, that you may have heard of, that folks with particularly Alzheimer's type dementia tend to do worse kind of as the sun starts to go down, and in the evening times. And so it would be important to note kind of if there's a pattern in terms of what you're noticing. So are they more confused in person because you're seeing them at a certain time? Are they more confused because you're seeing them, before they've taken some medication? So is it possibly medication related? For example, folks with diabetes who are on insulin, depending on how well controlled or poorly controlled their sugars are, that can lead to some cognitive symptoms. So it's important to kind of keep note of what the pattern is. And ultimately, if you have any concern, I always say there's no harm in getting evaluated and bringing it up as a flag for primary care. It's sort of notoriously neurocognitive disorders are diagnosed very frequently, not early in the presentation, but more mid to later in the presentation, mostly because folks kind of are not sure exactly what's going on, but we know that earlier intervention is better. And so if there's any concern, I would say definitely have a low bar to bring it up with your primary care provider or the primary care provider for your family member.
Okay, great. The next one I have is, does poor diet, and you kind of touched on this a minute with the sugar, does poor diet or lack of attention to eating meals increase depression?
That is a really interesting question. So there is a whole field of nutritional psychiatry that has been developing over the past several years and decades, just in terms of kind of what is the best brain food and what are the best nutritional ways to address what might be going on in terms of risk factors for depression and whatnot. I would say I don't know of any specific risk that comes with a poor diet. Of course, there are certain nutritional deficiencies which can lead to neurologic complications and psychiatric complications, for that matter. Things like vitamin deficiencies, folks who, for example, have alcohol use disorder and are not taking in very much food and just drinking, like those folks can come presenting with lots of different psychiatric symptoms, including depressive symptoms. However, I think in the context of the pandemic, I don't know that it's so much, it's sort of a chicken and egg type of situation, but I imagine that one of the symptoms of depression can be either overeating or loss of appetite. And so it may be that depressive symptoms are causing less attention to self-care, less attention to diet, and things of this nature. And so certainly taking care of one's diet, helping a loved one to have easier access to healthy, nutritious meals can be, I don't want to say it's a protective factor, but it can certainly help in terms of overall mental health and well-being.
Okay, great. We just have a couple more for you. Does isolation for older adults who have no pre-existing conditions reduce overall immunities?
I would say no. I think you're talking about specifically if there's some sort of like immune, something that's happening in the immune system that happens because you're not exposed to many other folks. And I would say no, there's no evidence of that. Okay.
Are there some concern about the side effects of the vaccine that's being discussed?
That's a great question, and something that I know a lot of us are thinking about and worrying about given how quickly the vaccines were developed. And I just want to say this. So the trial data that's been released for the Moderna and the Pfizer vaccines indicated basically the same side effects that you would get for a flu shot. So like arm tenderness, maybe some soreness or fatigue. No serious side effects have been reported as a result of the vaccine. And so I know everyone is concerned about whether or not to take the vaccine. And actually that's a huge public health issue in and of itself, vaccine hesitancy. We need to be able to get a large portion of our population protected with the vaccine so that we're able to kind of get over on the other side of this pandemic. And so I would encourage everyone, our institutions that are evaluating the vaccine are reliable. So I know that California has even created their own consortium, our state, with other Western states to take a look at the vaccines and take a look at the safety. And I am fully confident that any vaccine that's rolled out for us here in Orange County and Southern California will have been vetted, tested, studied, examined to the greatest extent. And I, just as a personal, endorsement, I am signing up. If I could have signed up as a trial participant, I would have, to get the vaccine as soon as possible.
Okay, great. And we have one final question. Non-access to internet is a very important barrier. How do you respond to those who are not connected?
Yeah, that's as I mentioned, 90+% of the participants that I'm seeing don't have reliable access for video conferencing for our visit, which I imagine means that they're not able to access it for primary care. They're not able to access it for friends and family who want to do FaceTime or Zoom. So I would say it's a matter of staying connected in, again, creative ways. So we have been able to maintain a sense of connectedness before the smartphone era, before there were laptops. And that just means being creative. So whether that is through, snail mail, through telephone calls, through seeing, having drive-by visits where you see someone, from the curb and say hello to someone in the door. I think there are ways to promote connectedness. It just requires being more creative. Now, in terms of delivery of services, I think that is a challenge that we are all facing, and that we, in the Reconnect program have also been grappling with. And I think it's just a matter of modifying. So modify to the extent to which you can, moving forward with the data that you can get with telephonic visits, and trying to do as much as possible, just knowing that kind of like the Swiss cheese model that's up, every intervention or everything that we try is probably going to have imperfections. Not one of them is going to be perfect in terms of, our aim of protecting mental health, of treatment, of maintaining the health of our older adults, but multiple layers improve upon success. And so multiple trials of different things, I think, will be have a higher chance of success.
Well, thank you, Dr. Park, for your very informative presentation.
Thank you.
Our next guest is Tony.